see. Where's my... All right, everybody. Thank you all for being here today. We're going to call this meeting to order. And our first thing on the agenda is customary housekeeping. If I can find these rules. Everyone, before you should have a copy of our committee rules for this biennial. Are there any questions?
Are they the same as last year?
Huh?
Are they the same as last year?
They are the same as last year with some minor tweaks maybe, but no substantive changes. That's correct. They are those that are recommended by leadership.
So question, can we get a tweaks on?
I can't hear you, Representative. Let me get you.
Just wanted to see what the tweaks are. If they're few.
We changed the quorum from 7 to 8. That's the only change, right? Okay. All right. 15.
Thank you, Mr. Chairman. I wanted to ask if you would entertain a motion to add a rule. And this rule is brought in the spirit of transparency. And, you know, I was thinking about we have a new cap on the number of bills that we can bring forward. So this might make it easier. But the rule I would like to suggest as a motion would be that we propose a 24-hour notice for all bills that we would be hearing or voting on to be shared with us digitally so that we'd have time to review.
Okay. So here's what I'll do. So I'll make first of all, we always do that. I hope that we did that. I don't know of an occasion where we failed to do that last year, but because I'm a stickler about that. I also always hear bills before we vote on them. We have a hearing in advance. So I'll not entertain that motion to change it in these rules because, as I just alluded to, we kind of have rules that are being recommended by leadership to each committee. So I'll not entertain that. However, I will promise you this. You will always have every bill you vote on, any new LC 24 hours in advance. Okay? All right. Any other questions? Number 17.
I was just going to make a motion to pass.
Okay. We have a motion to pass. Do we hear a second? All right. We have a motion to pass. We have a second. We're voting on the 25 to 2026 House Human Relations and Aging Committee rules. All in favor, say aye. Aye. Those opposed? Nay. All right. One nay. All right, the rules pass. Let's move on to some departmental. We have some good information here today. We're going to begin with the Department of Community Health. And my friends, let me just, we have new members here. Having long worked with the Department of Community Health, I'm going to take an opportunity to do something. Joe and Brandy, I hope you won't mind me doing this. You will find that these two individuals today for you, Mr. Joe Hood and Miss Brandy Sylvan, are some of the most helpful and knowledgeable people. If you have issues with your constituents, and I have never one time had an occasion when I reached out to you and you were not immediately responsive. And I can tell you that that is impressive to me, and I mean it. It's from my heart, and I appreciate you both and the knowledge you have and and this is why we've got to retain good people in our departments, folks, because we've got experience here that matters in terms of how we're able to serve the most vulnerable populations in this state. Ms. Sylvan, thank you for being here. Floor is yours. Podium.
All right. Thank you, Mr. Chairman, for the kind words. I'll catch up with you afterwards to get that thank you note over. But we appreciate you having us here today. I just wanted to briefly introduce myself. My name, well, it's kind of hard to, not sure the best place to position it. So I am Brandy Sylvan. I'm the Director of Government Relations for the department. So I wanted to make sure you all knew who I am and know my face and my name. If you have any questions about legislative issues that are being discussed or need assistance with constituent issues, feel free to contact me, and we will get you in touch with the right folks. And now I'm going to hand it over to Joe Hood. He is our Chief Operating Officer, and he is going to give some updates on a few initiatives we're working on in the department that would be of relevance to this committee.
Thank you, Brandon. Thank you, Mr. Chairman, for your kind words. Appreciate that. So I wanted to start out, before I go into the formal presentation that I have, the chairman had referenced a couple of items that I didn't have in the presentation, and I just wanted to speak to those first. They are big items and initiatives that we're undergoing. They just weren't what we had top of mind. So first of all, he had asked us about the CMO procurement, and many of you may have heard our commissioner speak to this. We have an open procurement to re-procure our care management organizations for Medicaid, and that is ongoing. It's under appeal. So we have initial intent to award, and then we have an appeal process. So we may have some time before we have new contracts. It may be a year or more for that to reach resolution. So what I'm speaking to will not occur until those new contracts are put into place and the appeals are resolved and we know who the care management organizations are. But in that regard, in the request for proposal and in the new contracts, there is a move or a shift of folks who are now served in the fee-for-service portion of Medicaid and served basically by the department, who will shift to care management organizations. And that initial population is a Social Security SSI qualifying individuals who are there. I think there's roughly maybe 200,000, depends upon when you look at that at a point in time. And those will shift from fee-for-service into care management. And that's the only change that happens immediately upon that new contract. Now, also in the RFP, there is a proposal and the opportunity to shift nursing home population and the waiver population just for the elderly that are there that the department manager manages to managed care. But that option isn't to be exercised or considered until you're 2 years into the contract. So that would mean we would have to execute, and we would have 2 successive years, and then we would be looking probably in that second year to make determinations if that's advantageous for the state. To be more transparent about that, I think it gives us an opportunity to see how we do with this first population that's going to move and how that's managed, and are we seeing the objectives met that we wanted. And it also gives us preparatory time for other opportunities to come to full fruition before we do consideration on moving the waivers and the nursing home population. Because the big thing behind that is to give managed care the opportunity to manage those who are in waivers and who are in this initial population so that they don't reach a point where they need to go to a nursing home. All of the savings that are projected are from keeping people in the community on waivers and as long as you can through a managed care process. But as I said, we want to wait and see how the first amount goes. And then additionally, the chairman had asked me about another opportunity that we're initiating, which I hope to have in place well before this contract is put out there, and that is called PACE, and it's alternatives for the elderly to enter into and stay in their home through what they call a PACE center. And many of y'all may be familiar. A PACE center would basically be in the community. I think of it like a senior living type place where you might go for lunch and that sort of thing, except it would have health care. It would have what they call an interdisciplinary team that does an assessment of the person, and then they come as frequently for health visits and other services as needed to that center. And the center has to be centrally located within time and distance opportunities, generally less than an hour or 50 miles, something to that extent, to be serviced. We have undergone that with the legislature's approval and the governor's signature of authorization to do PACE in Georgia. We expect to have that forthcoming very soon. We've undergone a lengthy process with actuaries to set a rate for that because it is a capitated rate where they're fully at risk as a provider. And then we've also had to do additional contract with Myers and Stafford, who has helped us develop the RFP. They've done this in other states. PACE is in about 30-plus states in the nation already and established, so long established, and there's a precedent there. We're trying to mimic that and have the least amount of challenge bringing that to market. We've done all the things to develop the RFP. We expect that we'll have our Department of Administrative Services approval very soon, and hopefully we'll have that released. And then we probably have a 30 to 60-day window of review and return and all the things before. But hopefully before the end of the fiscal year, we'll have the first of those out and in place. And then that would be another alternative to nursing home care before we address this in new contracts, and hopefully it would be established for a year or more before we get into the contracts. Those are the two items I think you asked me about, Mr. Chairman. Happy to answer any questions before I proceed to the other items we had.
There may be some questions on that first before you go to your main presentation.
Yes, sir.
I'm going to ask a couple first, Mr. Hood, about your very good, well done. First, just to remind everybody on the last issue we just discussed, on PACE, remember for new members here, we created the PACE program last year, working with the department through this committee, and we're very excited about that as a new way to keep people in the community for as long as possible. And excited to hear about this RFP, which is, I made notes here, very soon. We're excited about that. We're excited about that and the several communities it will begin in here in Georgia. Secondly, on the CMO, so the members will know, so that first population, Mr. Hood, that is going to be managed in the age-blind disabled world, which is all new to those of us that are here on this committee. That is new. We've not managed the care of these programs in the past. That is an asset. That is really individuals who right now are getting no services. They're not on waivers. They're not in their SSI, but they are not now in any official program.
They really
Is that
manage
correct?
their own care, to your point, I believe. So all their services are self-directed for the most part.
Gotcha.
That occur.
Gotcha. And then from there we'll move into the elderly and disabled waivers and so forth. And when Mr. Hood, when do you suspect we can't know this because we don't know how long the appeals last, but if you had to estimate when we start to see, because we've got folks here and that reach out to me pretty often involved in the waivers and other services, when do you think is the earliest likelihood we'll start to see the elderly and disabled waivers, SOURCE, CCSP, et cetera, move into managed care?
I don't know exactly to your point, Mr. Chairman, but what I will say is we've estimated that the appeal process may take as much as 2 years to resolve and do operational readiness and all the things that you have to translate for new CMOs. If it went as it were today, and I don't know that it will, we would have only one CMO that is in place in the old contract that would be on the new, and that would probably have some organizational change, and it might lengthen it. So let's just say it took 2 years. Then it takes another 2 years of contract before we would be there. That would be 4 years. So I would say between 3 and 4 years.
Okay.
And again, it's not an absolute. It is an option for the state to exercise.
Yes. Yes, sir.
So,
Thank you.
and between that time frame, as you're well aware, there'll be many changes at the state level, potential changes between the administration, CMS. We're all waiting to see how CMS changes as we move forward. So there's a
Yes,
lot of
sir.
potential for different
Very good
opportunities
point.
during that time frame.
Very good point. Thank you, Mr. Hood. Very good answer. Representative Scott has a.
Good afternoon, and thank you for bringing and for updating us. But I wanted to catch what you said about this Social Security is going to shift from. What is it going to shift from and going to where?
So today, there's a population that we're referencing. You qualify for Medicaid if you are disabled, age-blind or disabled on an SSI eligibility. So if the Social Security Administration qualifies you in a certain income category, you automatically qualify for Medicaid. And you're on what we call fee-for-service. That means you're not assigned to a care management organization. Most of our care management organizations, for example, today they manage pregnant women and children who are on there for Peach Care for Kids or the like. So that's the majority of that population. This would move those fee-for-service, those who qualify through the Social Security Administration's determination, into a care management organization, which means they would have, to the chairman's point, someone managing their care and, and sending them notice, most likely, you need to go and get a physical at this point in time. It's time for you to get a colonoscopy. Just the main things that we experience with a primary care physician, those are the types of expectations you would have from a care management organization so that they could make sure that you had preventive care in place to reduce long-term outcomes. That's largely what we're trying to exercise there.
Okay. Representative Cameron.
Mr. Hu, is this similar to DSNP?
Which one? I'm sorry.
Oh, the
PACE?
No, not the PACE, the other. If you manage care, is it going to be?
Well, managed care in it, in some regard, yes, because it's a capitated rate and they have to
dual
manage.
eligible?
Yes.
Okay.
There's similarities there.
Okay, thank you.
All right, Mr. Hood, let's let you continue with your presentation. Thank you.
Thank you, sir. So what we wanted to present today first, there were two items. The first has to do with behavioral health and community living licensing that is now with the Health Facility Regulation Division within the Department of Community Health. Some of you may be aware, but if not, the Department of Community Health has a division which is totally dedicated to Health Facility Regulation Division, and we have licensing for a number of facilities that are both state and federally overseen. The nursing home community, for example, has federal oversight that primarily is dominated through the CMS regulations. But then we have another set of programs which are state licensed programs, such as assisted living and personal care homes, which work in concert with, as an option, but they're not federally overseen. They don't have federal funding going to them. They're largely on a state paid or on a personal pay basis, and we license those as well. Those are the primary core that go hand in hand with our mission of long-term care and what we manage in Medicaid. But in addition to those, we have a number of state licensed entities that we're responsible for that came to us when the Department of when the Department of Human Resources broke up. All licensing was together, and we have behavioral health and CLA, or community living, which is largely DBHDD's management of that for the disability community, that are housed with us. And it's very difficult for us because us as a mission in Medicaid, we don't cover the policy aspects that are there through SAMHSA for behavioral health or for substance abuse that is covered in DBHDD. So we're bringing forth an initiative in concert with the chairman. We're hoping he's going to carry that for us and bring it forward, and I think we're in drafting right now, that would move the licensure that is appropriate for DBHDD, which is our behavioral health, for adult mental health, which is a new program we've just gotten underway, for narcotics treatments programs, for drug abuse treatment education programs, and then for community living, as I mentioned. Those would all shift from our licensure into the Department of Behavioral Health. And that way you have policy alignment at the federal level through SAMHSA, where that resides with DBHDD and all the policy folks they have over there for their state programs already that overlay with these licensures in that department. So the commissioners, my commissioner, Russell Carlson, and Commissioner Tanner, have both agreed that this alignment would be the best so that we would have community service that is aligned. And some of you who have been here for a little bit of time may recall that the chairman and others had study committees that ask about duplicity that we have in auditing efforts and enforcement efforts and survey related to these very issues between DBHDD and DCH. And while I think we did our very best, Mr. Chairman, to try and minimize that duplicity that we have in audit and in regulation, this will make that much better, I believe, by aligning it to one department where the policy area exists already, and you'll have one set of regulations. And as federal regulations change, DBHDD is in a much better position to make those changes and have awareness and make them consistent across the state. So in addition to the legislation that the chairman is bringing, if you have a review of the budget for that, you will see that we're aligning the budgets as well, and it references this change. So the budgetary amounts that we have in state funding to move the surveyors and the compliance specialists who would administer this today would shift to DBHDD to give them budget to do the same in that regard. So we think that this is great for constituents, it's great for efficiency and effective government, and very happy that the chairman has agreed to assist us with it. In the handout, you'll see, I don't want to go all the way through that and bore you. It goes through the benefits of the approach really that I've outlined, and it identifies all of the areas. And then the next item that I wanted to talk about were two recent bills that targeted improvement in certified nurse aid training, which DCH oversees. In 23, there was House Bill 497, which requires DCH to grant reciprocity to nurse aid applicants with appropriate professional educational backgrounds who are able to pass the competency exam. That exam is CMS-based because it's primarily for the nursing home community. Then we had a follow-up bill with Senate Bill 449, which removed the requirement for nurse aid training programs to meet federal standards and authorized DCH to provide 12 months of provisional reciprocity for military medical personnel. So we've been working on these in concert, but what I want to make sure everyone understands is we cannot remove federal regulation that's required for nursing homes. So we have to have the CNA that existed previously in place. So what we're talking about is adding an additional licensure just for state facilities. So our new CNA initiative, in response to the legislation, we've done a contract and we've worked with the University of Georgia to look at modular training curriculums, training reciprocity, and portable dimension training to further those efforts. But the main issue that I want to bring forward is the development of a new CNA. So this chart here delineates that if we were to create a state nurse aid and a state medication aid, that those would be available in our assisted living and our personal care homes, but not available in nursing homes because they wouldn't have the same level of qualification per federal regulation. And then we would maintain the CNAs that we have today and the certified medication aid that we have today with the nursing homes in concert so that we would have two different programs to address two different issues. And that's really how we plan to address the Senate bill. So the military would only be applicable to the new state program. But I think that is very meaningful for staff and particularly for assisted living and personal care homes because it gives them access to a greater array of staffing, and that's what we're trying to achieve there. Of course, we'll have training reciprocity. We've been working with the Georgia Department of Veterans Services to identify the military medical personnel who would be eligible, and then how that would be addressed with that new CNA opportunity. And then I think the last thing is portable dimension training that I had. So direct care staff must complete 16 hours of specialized dimension training before working in a memory care center or at an assisted living community. The proposed rule changes require only 4 hours of facility-specific dementia training for direct care staff who pass a dementia care competency exam. I think the point here is if you can pass the competency exam, then we can reduce the hours. But if you can't do that, then you probably need the additional hours to get to that point in time of competency. This initiative is being developed in partner with stakeholders and has broad support from the advocacy and the provider organizations because it's a compromise, right? We're trying to get to a competency exam that accomplishes what everyone is trying to achieve. The last point I wanted to make was a map that I pulled from Map to Care. And on the left, you see the personal care homes within the state. Well, I think the left is assisted living, and then the right is personal care homes. And overall, between these two, I think we have over 1,600 facilities that are particularly could be impacted by a new CNA state program. We only have, I don't want to say only, but we have 360 or so nursing homes. So from a facility count standpoint, a CNA program at the state level could be very productive because of the number of facilities we have on state licensure. And not everyone's aware of the state distribution of that, so I just wanted to enlighten that. Of course, the red, we have a lot of the larger facilities in metro area, but we really have a good number of facilities throughout the state of Georgia in assisted living and personal care homes that would be impacted. Mr. Chairman, that summarizes what we have, and of course, you have the presentation, and I think it'll be posted, so, but happy to answer any questions.
Mr. Hood, yeah, with the board is like, we have a lot of good questions here. I cannot tell you how excited I am. We have tried on this body here over the years, to do anything we can to make it easier for people to hire caregivers and worked on CNA. This is fantastic, and I appreciate y'all for that. The more we can do to get more people available as caregivers into this community, make it easy for them to do that. I'm really excited about everything here. We have a good number of questions. Chairman Bonner.
Thank you, Joe, for this presentation. Just a question regarding the service members you mentioned. Do you number one, what does that pipeline look like, and then what is your expectation for the numbers of those personnel that would be available?
I really don't have a good feel for that, to be honest. We've got to finalize the CNA track and make sure that we've got good alignment, and then that would tell us how many of what they're bringing over from the Veterans Administration would comport to that. It's difficult for me to answer that right now. I just don't know number-wise.
And so is the goal, again, like to take, I mean, someone who, for instance, already had combat lifesaver training versus someone who's in a mechanic and is going to be retraining into that once?
Oh, absolutely. I'm sorry. It will match skill sets to the state CNA licensure for, yes, absolutely. That's what we would intend to do and to match. And that would be the requirement. And that was what was proposed in the legislation, is they're looking to match like skill sets. And if you have that skill set and it completes what's in there for the CNA certification, then that's what we would want to do.
Representative Lupton.
Thank you, Mr. Chair. For the portable dementia training, the care competency exam, is that something that exists already, or is that an exam that needs to be developed? And who would be developing that test?
So I'm a little bit at a loss because I'll apologize. Melanie Simon is my expert on this. She's our general counsel, and she developed and worked with the advocacies on that.
Okay.
I'm going to say what I believe is the answer, but I may be mistaken. So just that caveat. I believe that that's something that already exists, that we've coordinated with the advocates on to adopt and bring forward. But I don't believe we brought that all the way forward in administrative rules, so I don't believe it's finalized or complete yet. But my understanding is it was something that was already in place that we were trying to adopt to bring forward, that it wasn't going to be something that was going to be created. Because my understanding is when we bring it forward in rule, it will be something we could act upon.
Okay, so it's not a federally designed test, it's something that the state has designed. I'm seeing like shaking of heads and nodding of heads over here.
Yes.
Okay.
I think both of these were done through UGA in some respect.
Okay, thank you so much.
All right. Chairman LaHood, I think you brought us the bill that gave us medication aids, if I recall. Chairman LaHood.
Thank you, Mr. Chairman. Thanks, Joe. To your question, I believe the intent is to not to lower or raise a standard in dementia training. I think it's just to make it where it can be portable. Yeah. Like if they satisfied the training with one employer, they could follow them to another employer. I think is the goal. My question was going back to the state nurse aide.
Yes, sir.
That would be meet the requirements to work or to become a CMA or sit for the CMA test in a assisted living or personal care home, but not necessarily skilled. When do you expect to have that? No, that's something we've been looking at for a while.
I'll have to get back to you, Mr. Chairman. I really don't know the timeline of when that'll be complete. I know we've been working on that for some time because I've renewed that contract twice as we've started. We started much broader, and we've narrowed down to get to where we think we can have an actionable program. I just don't know how close we are to a completion.
Okay. All right. Well, thank you for acknowledging the pain points
Yes, sir.
employers in that industry are dealing with, and anything we can do to get some relief would be helpful for those employers. And thanks for all you're doing.
Yes, sir.
Glad y'all are here to present
Yes,
to
sir.
us today. Thank you.
Representative Jackson.
Thank you. Thank you, Mr. Chairman. I may have missed what you were saying about the PACE program, and where are your centers located? Have you found a location? Do you have a list of locations where those centers are located?
Thank you for that question. So the primary, and I didn't cover this well, so I apologize. The request for proposal, this is a Medicare program, so we are going to use Medicare regulations in regard to how it's administered, and Medicare funds a portion of the monthly rate that goes toward that. So part of our partnership with the Centers for Medicare and Medicaid is that the state needs to decide who is authorized to open a PACE program and where it will be. So I'd reference Myers and Stafford. We contracted with Myers and Stafford almost a year ago to go out and do a review of the population. We also worked with National PACE, and they have a formula which, through population census and through other means, determines where the populations are that would be best served by a PACE program. And then they come up with recommendations. From a business model standpoint, you probably need about 300 or so, maybe 250, somewhere in that range to break even to do a PACE program. It's generally going to be at least a 10,000 square foot building with medical staff and all the things. So you're looking at a sizable investment. It's much like, in some regards, opening a nursing home. You've got to be fully staffed and have all that to serve, except you're serving a greater number of people. So we are tasked with where should those be. So Myers made recommendations where we would ask the respondents in the request for proposal to propose those centers to be. So we have, in our initial rollout, we are looking at 3 different locations in metropolitan Atlanta, a location in Savannah, a location in Columbus, and a location in Macon. And I believe that that will equate to 6 centers, maybe 7 centers. We also have an opportunity for those who have a specialized population to respond if they are in a particular area and established. So there will be 6 or 7 that we anticipate in this first RFP, but we won't know exactly where they are until they respond, propose it, and what we do is award zip codes. And basically we're saying to them, within this number of zip codes in South Atlanta, for example, you can establish 1 or 2 PACE centers, and we award those, and then they go to CMS and get the sign-off, and then they commence either building or leasing space to do that.
Do you have a minimum number that you have to have?
A minimum number of participants?
Yes.
There's not a minimum number of participants, but to make it work from a business standpoint, that's the number that I was referencing. They generally have to be in that 250 range to 300 to make enough money to break even to pay staff. And generally, they're probably going to target for a much greater number. My understanding is it may take up to 2 years to enroll. Once they get started, the average is 8 to 10 members every month if they have a good marketing program. And then that just, that continues to grow as they do, and it may take them up to 2 years to get to 250. Some of the ones that I visited at the national conference had been there for 3-4 years. They had 350, 400. I saw one that had been there for, I think, almost a decade. They had 1,000 folks, and they had multiple sites to support that. So it's going to just depend upon the site and how robust the enrollment is.
Thank you, Representative Jackson. Okay, Representative Bazemore, we're going to take 2 more questions. Representative Bazemore.
Thank you, Mr. Chair, and thank you, Joe, for your detailed presentation. Appreciate it. My question is, based on the fact that, from what I'm hearing, we're going to rely on federal dollars for some of these changes and some of these programs. Do you anticipate a negative effect or backlash based on what's going on in D.C. right now?
You're referencing PACE particularly when you ask that?
Anything that's federal.
So PACE
monies.
is a Medicare program. It's primarily it's primarily the most federal program that I've referenced today. The other ones are state licensed programs. So, but to answer in that regard, I don't believe so. That's a well-established program, like I said, in over 30 states, and it's Medicare based. I'll give you an example. We did have a recent hiccup where there was some funding that was paused. Many of y'all may be aware of that. And we had some concern. They only addressed Medicaid there. They exempted Medicare from the very start. And with PACE being a Medicare program, with that kind of clue, I don't think so. And then they came back and rescinded and restored we got funding payments and came forward with that. So my thought is that that will not be an impact to Medicaid going forward.
Thank you.
Very
Appreciate it.
good. Representative Kimball.
Thank you, Mr. Chairman. And again, thank you for this very detailed presentation. I have two questions. The first question is, jumping back to the CMO procurement, and you had mentioned after sort of 2 years, you would be able to begin to see the effectiveness and the results. I'm just curious to know, where could we find at this point or in the future what criteria would be used to judge whether or not it was successful or not? So I'm sure you mentioned, obviously, trying to keep people in their homes would be one measure of success, patient quality of care, but also health of patient population, probably some cost savings. How do we wrap our arms around what criteria will be used and be tracking that with you?
The honest answer is I don't know exactly at that point in time what will be used. So I'm going to hypothesize with you what I think my personal opinion is will happen in that regard. So that first population, they don't have any managed care today. So when it was proposed that we move them into managed care, what's supposed to occur is you're supposed to have reduced health care costs because they are now getting preventive care and scrutinized that, you should do X, Y, Z, just like all of us do with primary care. So what happens, and I know that y'all may not be aware of how this occurs each year, but in our department, we have an actuarial team that is contracted. Right now it's Deloitte & Touche is who does that for us. And each year, we go through a process to develop the budget and develop the capitated rate for that with the CMOs. And you go through what the costs have been, every component cost of that, what we call a PMPM, per member per month payment. So my expectation is we will see, okay, we moved this population, it's been there a year. Did the costs go down as compared to the fee-for-service expenditures that we were doing before? Did we meet expectations as the CMOs indicated they thought would occur? That's really one of the primary measures, and that would accomplish a lot of things. You may not get the long-term health outcomes, but do you see that we're getting more primary care visits than we were before? Are we getting more psychological visits? Or are we doing all the things that we would anticipate that maybe we weren't doing before on preventive care? And we would see that in the rates. And I'll give you an example of how I know that occurs. Y'all may remember that we had autism and ABA as a developed certification for Medicaid some years ago. When I went through my Medicaid rate development this year, we go to them and the actuaries tell them all the things that they took into account, and each of the CMOs get to come back and tell us where they think that there's an increase in utilization and an increase in cost. And ABA was number one in every one of those to show that we were successful because they had enrolled providers statewide and the cost for ABA had gone up for each one of them on utilization across the board. And that was our expectation. I really was very happy to see that. I don't know that they were very happy because their costs were going up, and that's what they were trying to exercise, is that we needed to make sure we had enough in the rate to accommodate that. But I expect we would see similar things in this population. And the populations are specialized by cell, by age, and by eligibility type. So we would definitively be able to isolate that and see that within the department. Now, to be honest, I don't know how much of that is going to get shared. And rate development is usually a proprietary thing. We meet with each CMO to talk through it, and then we do generalize as a group whatever's applicable. But that is how the department's going to evaluate it, I suspect.
Okay, appreciate that. Would advocate for, obviously on behalf of.
Okay. Go ahead.
I think just in terms of our constituents, greater transparency in terms of, outcomes, whatever they are, is
Certainly.
appreciated. The second question is kind of back to the modular training curriculum, and I think I understand, but I just want to confirm. You said, obviously, we're trying to have increase of certified providers, and because we need that staff now. And the modular training allows folks who are in a course of study to have this a certified medication aide with fewer hours. So it's going, the certified nurse aide needs a minimum of 75 hours, and the certified medication aide needs 40 hours, and then takes a new, possibly state nurse aide exam. Am I understanding that correctly? And is it such that a person could just stay in that level and then practice at that level, or are they already enrolled in these longer training programs to, at some point, become a certified medication aide? Or, sorry, the certified nurse aide.
Okay, if I don't answer your question, just, we'll do a follow-up. But, in the nursing home program, there is CMS regulations that do the CNA training, and they mandate that, and we have a contract, and there's a private party that does all that, and that's really speaking to those hours. So what we're talking about doing, and we built upon that when we did medication aid. Medication aid is not really a CMS convolute. We did that in state law, but the way that we accomplished that to be a nursing home is to say, well, you've got to have a base of being CNA certified already, and then we're going to apply CMA on top of that. But that really creates a challenge in assisted living where they did not have a CNA base. They have other staff, other care staff which do similar tasks, but you don't have the same level of acuity in assisted living generally, right? You don't have nursing care to that standard and all the things. So what we're doing in the state program is saying, okay, you can start from a different level and let's only encompass what you need for that particular discipline in that acuity level, and that's going to reduce the number of hours because we're not requiring you to, like if you don't have a bedridden person like you might have in a nursing home, we're not requiring you to get to that level of skill, right? Now to answer your question, not really. I mean, they could continue on, but they're going to have to go and address the requirements for a CNA training to be in a nursing home. And where there might be overlay, it's just like anything else on a professional license. There's overlay in all of our different disciplines, but generally you're going to still have to go and take the hours and get to the place to do that licensure type.
Thank you.
Thank you, Mr. Hood. I tell you, again, I cannot tell you how much I appreciate having you and Ms. Sylvan available to our constituents. I have a question here from one of our representatives who, if you could give us your contact information. I have it, but I think, and I can send it out, or you can, however you want to do it.
I just point you to Brandy on that. She has everyone's contact.
Okay, we'll just, why don't you just get it to us and we'll disseminate it then, Amber? And, okay, gotcha, that'll be fine. But thank you again, that was most helpful. We're going to move right on. We're going to get an update in the, in the limits of time. We might do more of this. We're going to get an update from two industries that are vitally important to the people that we address in this body. We're going to begin with the Georgia Healthcare Association. And you have the floor, Seth.
Thank you, Mr. Chairman, members of the committee. I'm Seth Coker, Vice President of Government Relations for the Georgia Healthcare Association. Pam Clayton is here with me as well. She's Vice President of Quality Advancement. Is that right? Regulatory Affairs. It's a long title, it's both. And that's why she's here. She has so much knowledge for y'all. But we're going to give you a kind of high level of who we are, who we serve, some struggles we have, and some opportunities that we may have in the future. So we're an association that represents skilled nursing centers, assisted living communities, and home and community-based service providers, representing the best interests of residents and patients, as well as owners, administrators, and other personnel. So our main goal, we're committed to continuously improve the quality of life of all persons requiring long-term health care. And y'all do have my slides, don't you? Just a quick look at who we serve. So this is the association. These are our members. So 342 skilled nursing providers, 66 assisted living providers, 22 elderly and disabled waiver providers, and 159 associate members. And this graph is Georgia as a whole. You can see as fiscal year 22 and fiscal year 23, you can see the nursing center number did not change, the nursing center beds did not change. But towards the bottom, you can see our number of residents that are getting older, so our aging population is getting bigger. I won't read out all those numbers, but you can see that's Georgia demographics as a whole. I'm going to turn over to Pam for the satisfaction surveys.
Thank you for that, Mr. Chairman, committee members. Thank you so much for the opportunity to be here. I greatly appreciate it. So wanted to lead with a bit of good news. I'm sure heavy weighs the responsibility with the decision-making that you have to care for the vulnerable population here in Georgia. And just wanted to share the great news just simply because we're coming out of the season of satisfaction surveys. We conduct and have for over 20 years conducted a satisfaction survey through a third party that surveys residents, family members, associates within skilled nursing centers and also within the elderly and disabled waiver program to discern their satisfaction and kind of how we're doing. It's a pretty detailed process. But we heard from over 34,000 individuals just within the skilled nursing center space alone, within the nursing homes, and they're expressing high levels of satisfaction. We're going to talk about workforce here in just a bit, but we do include it in that process an employee survey. And they provided feedback that training and education, as well as the work environment, inspires them and allows them to do their best work. And they saw that as their greatest strength. And I think that's just really foundationally important as we struggle with workforce challenges, and we'll talk more about that in a minute. And then certainly trust, respect, and safety identified by family members and residents as some of the areas of greatest strength. And I know that's important to you all just as it is to us. And finally, I would just conclude with the elderly and disabled waiver community. Their satisfaction in every dimension of care and service that was surveyed improved year over year. So just really great results. And they actually came away with what is deemed as a world-class Net Promoter Score. So I think that's important for us all to recognize that, really great quality care is being delivered and folks are satisfied and grateful for that. Always opportunity, and we'll talk about that in just a minute, but wanted to begin with that bit of good feedback. Workforce certainly does continue to be one of our greatest challenges. Those challenges predate COVID-19. I think President and CEO Chris Downing often kind of refers to it as a COVID hangover, in that it's really not completely in the rearview mirror, and certainly not as it relates to workforce. We lost about 5,300 caregivers from our profession during COVID, and we still need about 1,200 to get back to where we were pre-pandemic. And so that is a significant strain as you think about trying to meet the needs and the services that Georgia's vulnerable populations so very much deserve. And so we continue to work with the department. Mr. Hood, others at DCH have been a great partner to look at ways to address that, but it certainly continues to be one of our greatest challenges. And Georgia has some of the lowest employed RN to population ratios in the country, and that is not anecdotal. That is an absolute statistic that I know we all would love to change, and certainly there are focus around that. And then finally, I just want to make a point around agency utilization for staffing and augmenting the workforce. That continues to be a reality. Tremendous increases in that, of course, over the course of the pandemic, and that persists. I have a concern, a deep concern, of course, in terms of cost, but also in terms of quality of care, continuity of care. I'm certainly not going to say that it makes that impossible to deliver upon, but it lends to the challenge. And when you think about liability concerns and risk management and those different pieces, agency utilization, continuity in care, satisfaction, all have the potential to be impacted in a significant way. So we very much need to continue to focus on workforce, look at ways to build that, and allow us to continue to meet the individual's needs in the setting of their choice in a quality way. And Seth, you want to touch on reimbursement?
So as Pam said, workforce is a big deal, but also reimbursement is as well. I'm sure y'all, some or most of you probably know that we get our cost reports through the state budget each year. As you can see, Georgia has the next to lowest Medicaid reimbursement rate in the Southeast. We are thankful to Governor Kemp A couple years ago, everybody agreed to go to update the annual reimbursement rates for nursing homes to reflect the annual growth in cost. However, there's a gap. To give you an example, right now we're on the amended FY25 budget, which we are shoring up the 2022 cost report. So, we're moving into the fiscal year 26. So in FY26, it's the 23 cost report. So there's a gap in there. So there's still money needed for reimbursement rates to address inflation. Just we're a couple years off. So that's how reimbursement rates work. They're usually in the amended and the big budget. We did do a margin study. We hired an outside firm just to show you how big our margins are. The combined margin for 297 nursing facilities was negative $139.3 million, so representing a negative margin percentage of 5.4%. So it's a big number of how far we're off. And I'll let Pam talk on quality.
And we would love to share some specifics from that margin study and cost analysis with you all if that would be helpful, because I think it's really telling when you think about trying to accomplish a lot of these challenges that we have and confront them in that environment. We are grateful that despite the challenges, the workforce challenges, and other things that they confront, the providers continue to evolve and innovate to ensure that they're ready to meet the needs of the growing elderly population here in Georgia. And by that, I mean they're really looking at their service delivery models. They're providing dialysis, for example, in place within the skilled nursing centers, a really strong focus on mental health service programs, behavioral health, because we know, I think you all are acutely aware of the need around that. And so we continue to certainly try to be responsive relative to the needs of the individuals that we serve and keep a strong focus on quality, systematic quality improvement. We have folks that, Mr. Hood talked a lot about federal regulations, state regulations, so kind of that's that minimum level of, no problem at all, thank you so much. That minimum level of compliance, but and that's challenging. Sometimes that survey regulatory framework is challenging to function within, but they're going above and beyond and attaining quality award status, pursuing the quality awards following the Malcolm Baldrige quality framework, and also even Joint Commission accreditation. 143 centers here in Georgia have that accreditation. So I just want to reassure you that that commitment and focus on quality is strong, and it really is what guides us. I will touch just briefly on the CMS staffing mandate. I know that you all have heard much about this in the past. Many of you were very helpful in sharing concerns about this staffing mandate put forward at the federal level. While there is certainly a lot happening presently within the federal landscape, and we're watching that closely, this is still in play. And this staffing mandate is mandating specific staffing levels, specific RN levels, and I've just talked with you about the workforce challenges that we already have, and so we're deeply concerned, should this continue to move forward, how will we be compliant and how will we confront that requirement? So we're continuing to watch that closely and certainly recognize and hope for there's some legal action occurring at the national level relative to getting relief either through executive action or through rules, and so we're certainly supportive of that, but know that it is there and would require a significant increase in workforce to be compliant. So we recognize that we have a burgeoning aging population here in Georgia, which is wonderful. Georgia is attractive to a lot of people, but we have a critically strained workforce. And how do we confront and meet the needs of the vulnerable Georgians that we serve in the manner that they most desire? And so we want to rise to that challenge, but it is a challenge, and there's a validated correlation of resource to quality. So you have to have the resources in order to deliver on the quality of care and service that you desire to, and workforce certainly impacts that and threatens access to care, quite honestly. So as we think about opportunities and kind of what keeps us up at night, workforce expansion, development, and resiliency is critical. We're grateful for all that you all have done to date to support in that way. We're grateful for the opportunity to work with the department on pathways, easing the burden of testing and any barriers around that. They've really done some great things over the past year or so to help us with the throughput of workforce, and we need to continue to focus around that. I would also share that investment in aging physical plants to promote quality of life, promote safety, and mitigate the adverse impacts of disaster is an area of focus, and we would love the opportunity to talk with you more around that. And finally, I'll just close in the interest of time around healthcare liability reform, also known as tort reform, certainly being something that we're very interested in, we desperately need. When you think about resources for quality of care and service, and honestly just being able to keep your doors open to meet the needs of the communities that you serve within, the healthcare liability issue and the costs associated with that, it's a really trickle-down effect to the bedside. And we have to be cognizant of that, and it also honestly impacts those healthcare professionals that are serving. And I can't tell you the conversations that we have with physicians and others around, I just don't know how much more I can do. So I want to let you know that that certainly is an area that we are concerned about. And
Thank you so much, and I'm sorry, we just learned there's a 3 o'clock meeting, so no, we're not gonna stop. Everybody stick with us. We're gonna hear from the Senior Living Association, but for that reason, we're gonna move on, and thank you so much. We're not gonna take any questions, but that was very helpful information about an industry that's so important to the most sick and vulnerable people in our state. Thank y'all, well done. The Georgia Senior Living Association, can y'all please give us a good update on the other side, residentially? They're actually on the agenda, let's see here, yeah, this is separated out. So now the non-skilled side.
Yes.
Floor is yours, sir.
Okay, do we have a presentation? Okay.
Could use the, I know it's a little tight there, but if you can use the microphone, it'll be better to hear.
Is this better? Here we go. Okay. All right. Thank you, Mr. Chairman, members of the committee, for this opportunity to address y'all today. My name is Seth Daniels, Director of Government Affairs for the Georgia Senior Living Association. We'll figure out some way to keep it separate between me and Seth Coker. We're working on that. Similar industries and exact same name. This committee is well-timed. Today was Georgia Senior Living Day at the Capitol, so hopefully many of you got to meet with constituents who are in the assisted living industry in your communities and got to hear from them personally. Do have with me today our President and CEO, Katie Ramp, and also some of our members here, providers of assisted living, and a couple of our industry partners as well that support our industry. So what we mean when we say senior living, when we're talking about the non-skilled side of long-term care, we're talking about assisted living, personal care home, and memory care. We include a little bit because there is some overlap. Typically, there is an independent living component on the same campus as we will have the assisted living services, but there are standalone independent living as well. We distinguish ourselves from the skilled nursing facilities. They're a vital part of the long-term care ecosystem, but they're a different world. They're CMS certified. They get Medicaid reimbursement. We don't. We are a private pay, consumer choice driven industry. So we provide quality care to our residents at no cost to the state. We also do not include in our, what we talk about in senior living, the senior apartments, the 55 and up and the 62 and up apartments that you see popping up everywhere. Again, those are great opportunities for seniors, but there's no healthcare component to them, and they don't have typically the communal meals that we offer. So by the numbers, there are 43,150 seniors in Georgia living in assisted living communities, 1,673 communities, and in Joe's presentation earlier, you saw the breakout. That's about 300 are certified as assisted living, 1,300 certified as personal care homes, 21,000 jobs directly through our communities, another 18,000 support the industry, and a $5 billion economic impact per year. I mentioned earlier our residents choose assisted living. We are a consumer choice-driven industry. They choose us. We are, compared to other alternative settings, more affordable. According to J.D. Power consumer surveys, have very high rates of satisfaction. They report being very satisfied with their care and their improved quality of life. Yes, so these are just sort of by the numbers. Our average cost, Georgia ranks near the bottom compared to other states for the cost of assisted living. Workforce, y'all have heard about it today. We're very encouraged to hear the update from Joe Hood at DCH about the SNA and SMA program. We have been working with them on that and the development of the portable dementia exam. Glad to hear the update from them and that is moving along. Just some more numbers here about the growth of the aging population in Georgia. In 5 years, more than 20% of our state's population is going to be 65 or older. There's incredible demand coming now and coming down the road to provide affordable, accessible care for people in a vulnerable stage of life. 96% of senior living communities report staffing shortages, which is not to say that we're not meeting the standards set by state law and reg. It just means that it's hard to. It means calling people in for longer shifts, for double shifts, asking people to do more, where we would like to lower the burden on our caregivers because this is a difficult job. Licensed healthcare professionals and administrators are our biggest need, but we employ people in a range of career fields and see staffing challenges here as well. We've got great opportunities, great career opportunities for people in a variety of fields, in food service, in hospitality, in the business offices, and resident activities, but we like the people to fill them. Again, encouraged from the update from DCH about ways to plug those gaps on the caregiver side, but we have a lot going on, and we need some people in this space. Workforce, again, I want to reiterate. But like every other business in Georgia, we're facing unsustainable insurance premium hikes and increasingly hostile litigation environment. According to Senior Housing News, in 2023 alone, there was a 24% increase to annual premiums, and in the second quarter, an additional increase of 19%. This really threatens the availability, accessibility of care. Again, if the residents in our communities are not drawing on Medicaid dollars, we're able to provide that care at no cost to the state, but the current litigation and insurance environment is making that increasingly difficult to do. A couple other things to note. You've heard of FinTech. Well, we have Age Tech. Georgia and Atlanta particularly is a growing hub for age tech and aging technologies. And many of our communities are adopting emerging technologies, including AI for fall detection and predictive analysis of resident needs in health emergencies. This is a growing space that we're excited to be partners in, and we're really encouraged by the developments that are coming out. Resident care, person-centered care is our standard of care delivery, places the need of the resident as the foremost priority. Value-based care is sort of the next standard up, and it is a resident-focused care metric that uses data to help predict care needs with individual resident in focus. Although not required, many providers now use value-based care as their primary care delivery focus. We've talked about the growing need to meet the demand as Georgia grows as a retirement destination, but I want to reiterate that again here as well. And lastly, Georgia Senior Living Association. So we do advocacy on behalf of the industry. I'm here We also work with Georgia Link as our external partners here at the Capitol. But we also do education for our members, particularly our caregivers. In 2024, we had 58 educational events across the state throughout the year, and 84 NAB accredited continuing education credits. So a lot of our care workers get their education and maintain their licenses through our education programs. I think going back a little bit to the numbers of how many communities there are in Georgia, we represent about 85% of those. So of the 1,673, we are most of them, and we only draw our membership from the list of registered and licensed by the state. So we don't have any unlicensed facilities in our membership. So. All right, that was abbreviated for time and because you've
Well
heard
done,
so
sir.
much.
Well, listen, let me say a few things. So a few things you touched on, I just want everybody here to recognize. So this is a private sector industry.
Yes.
Overwhelmingly. And I think our members need to recognize that because our skilled, and we need all of these, our skilled nursing facilities are so important to this state, our assisted living facilities, our personal care homes. But about today, 73% of our skilled nursing facility beds are Medicaid, which means they're paid for by taxpayers. A good chunk of those are Medicare as well. But the personal care homes, the assisted living communities, and all of the assisted living facilities, we have all these different licensures. Those are completely private sector, with the exception of a small group, Brandy, of waivered clients under the Medicaid waivers, but overwhelmingly a private. So what that means is that those individuals that might otherwise be in institutional settings paid for by taxpayers are being cared for privately in the community, not the burden of taxpayers. So it's a profound impact. Your industry has a profound impact on society, and I appreciate y'all being here. Very, very helpful for everybody here to get an update. Folks, I want to make sure everybody here on the committee knows that we have a new policy analyst, and that is Miss Amber Mack, who is lovely. And I'm so glad we have her. And we have a new legislative council member, maybe a fellow Irishman back there, because his name is Hennessy. I like him already. I like good Hennessy. So anyway, all right, guys. So at any rate, thank you all for being here. This was very helpful. Everybody here today, I hope it was helpful to all our members. We'll be back soon with some bills. We have some coming in as we speak. So this meeting is adjourned.
All right, thank y'all.
We didn't get that chance to ask any
Good afternoon, everybody, and thank you for being here. We needed a quorum to be able to pass these rules, so I'm so thankful that everybody's here today. I'd like to have my vice chair, Representative Stinson, to just say a little prayer for us.
Oh, absolutely.
Thank you.
I'd be honored to. May we pray. Oh, dear Heavenly Father, we come to you this afternoon as grateful as we know how, thanking you, dear God, for all your many blessings. And dear God, we pray and ask you to be in the midst of this meeting. Let everything be done decent and ordered and pleasing in your sight. For it's in the mighty name of Jesus we do pray. Amen.
Amen.
Thank you. I think everybody has a copy of the rules. Uh-oh.
This should be the third page.
Okay.
Oh,
Did you not get it?
Here you go.
Oh, you know, it's in my bag. That's why she got my
Oh, here you go. Just take that.
There's some. There.
Thank you. Now
There. Okay, now everybody's got them? Okay, I'm going to give you a second to read through them real quick. And I will entertain a motion. I have a do pass. Do I have a second? I have a do pass and a second. All those in favor say aye.
Aye.
And, oh, I'm sorry. Representative Jackson?
Madam Chair, at the convenient time, would like to make a friendly motion to change number 2 from 5 members to 9 members. That will give us a 50% composition when you have a body of 18.
I'll recognize that motion for discussion. Oh, I have to have a second. I'm sorry. Do I have a second?
Second.
Okay, now we can have discussion. Number 3, who's number 3? Okay.
That was me. It's the same thing.
Okay, number 5, who's that? Oh,
That's me.
Chair Lady Camp.
Thank you, Madam Chairwoman. I just want to mention that in many other committees, because of the issues with meeting composition and getting members here when we have conflicting meetings, many other committees have opted to do more of a 25 to 30%, simply because we won't be able to have a meeting in the event. Even today, it was somewhat of a challenge to get members here on time to meet a quorum. As of 3 o'clock, we did not have a quorum for this event. So that's just something I'd like to state. Is that not true?
Yes, ma'am. That is very true.
Thank you.
Thank you. Chairman Crow?
Yes, ma'am. I just wanted to echo Chair Camp's. We had our first committee meeting for Public Safety and Homeland Security today. We have 22 members, and our quorum is also 5. Just because there's so many meetings happening at the same time, it's hard to get enough people there to even start the meeting without a quorum. And so it's, I think most chairs have been through discussion and encouragement, have been setting the number a little lower just so we can get those meetings started. We have to have a quorum to commence, and so that's what we did in that committee.
Thank you, sir. Is there anyone else? Okay. Chair, Representative Jackson?
Madam Chair, I certainly acknowledge what my colleagues are saying, but it would be helpful when we go back to our districts to be able to explain to our constituents that it was 50% of this committee that made decisions on certain legislation versus 33%. And so in keeping with everything else in our democracy, it's always healthy for at least 50% plus 1 to represent that. So if our quorum today was 9, I think even based on starting a little bit late, we would have still had 9 members eventually, because we got 18 right now. So, I get the complexity that we all have committee meetings, but if there's a certain matter, I think that this body will be responsible enough to make sure that we have a quorum so we can do the work for the people of Georgia.
Thank you. Who's number 8? Chairman Rhodes?
Madam Chair, I just wanted to echo what's been said before. I just wanted to let you know that the quorum on my committee is 5 also. Yes, ma'am.
Thank you, sir. All those in favor, raise your hand. In favor of Representative Jackson upping the quorum to, what do you say, 9? All those in favor, raise your hand. All, okay, 2, 3, 4. And all those opposed? And the opposition has it. Thank you. Now, I will entertain a motion to do pass the committee rules. Thank you, Chairman Rhodes. Do I have? Second. Do I have a second? I have the second. Is there a discussion on that? All those in favor, raise your hand. Okay. 8. And all those opposed? 3. Vice Chair, and it passes 8-3. Thank you, everybody. Vice Chair Stinson?
Yes, ma'am. I just want to make a comment, just so the new members will know my reasoning for the way I voted. Is because I know as it gets deeper into this legislative session, there's going to be many times that there's going to be 2 or 3 meetings going on at the same time. And I've been in positions where we have to sit and wait for members to come in to get a quorum. Then by the time you get a quorum, because we waited so late to start, then there's another meeting getting ready to start, then you got to jump up and run out of this meeting and get to another meeting. And a lot of times work don't really get done like it needs to a lot of times. So that's my reasoning for voting with the 5 members as a quorum.
Thank you so much. I appreciate that. Before I have everybody introduce themselves, I'd like to read the history and the duties of the Planning and Community Affairs. This committee has traditionally been assigned general legislation that affects Georgia's local governments. Examples of bills that have been and are handled by the committee include legislation establishing annexation and zoning procedures, authorities, state symbols, state holidays, state recognition of Indian tribes, and regional development centers. Additionally, election law bills, bills establishing guidelines for local government planning, bills incorporating municipalities, and bills determining county boundaries have also been processed through this committee in the past. So I just wanted everybody to hear that so that you kind of knew what you were getting into in this committee. Representative Campbell, could you start and just tell us, of course, your name and your district?
I'm Joe Campbell. My district is 171, which is very southwest Georgia. Decatur, which is Bainbridge, Cairo, Grady County, and Mitchell County is Camilla. Very Alabama corner of Georgia and Florida, and it's a very heavy agricultural area.
Thank you. Chairman Rhodes?
Yes, ma'am. My name is Trey Rhodes, House District 124. My district consists of Putnam, Greene, Tolliver, Oglethorpe, and I swing up into the east side of Clark County.
Thank you. Representative Kahan?
I'm Noelle Kahan. I represent the hardworking people of District 81, and that's in Henry County, McDonough, and Locust Grove.
Chair Lady Camp?
Thank you, Madam Chair. My name is Beth Camp, and I represent District 135, which is in west central Georgia, and I have portions of Spalding County, which I share with Chair Mathiak, Lamar County, and I have all of Pike County, Georgia.
Thank you. Representative Flournoy.
Thank you, Madam Chair. My name is Robert Flournoy, and I represent District 74, which is a newly drawn district which covers part of Clayton County and Henry County, so that's Hampton, Lovejoy, and Jonesboro.
Thank you. Chairman Crow, excuse me.
No worries. Thank you, Madam Chair. Representative Clint Crow, I represent the 118th District, which consists of the southern half of Newton County, all of Butts County, and the northern half, essentially, of Monroe County.
Thank you. Representative Jackson.
Thank you, Madam Chair. Derek Jackson. I represent the 68th District, which consists of South Fulton and Fayette County. That I used to cover 7 cities, now 6, Tyrone, Peachtree City, Fayetteville, and then I go into Fulton County, Union City, Fairburn, and the city of South Fulton.
Thank you. Representative Westbrook.
I represent Georgia House District 163, which is a large portion of the city of Savannah, a portion of Garden City, the town of Vernonburg, and parts of unincorporated Chatham County.
Thank you. Representative Berry.
Thank you, Madam Chair. Representative Bryce Berry from District 56, hailing from Southwest Atlanta, downtown, and Midtown Atlanta.
Thank you. The other half of the chiropractic caucus. Representative Jones.
Thank you, Chairwoman Karen. I give you greetings all the way from the heart of Georgia, Macon and Warner Robins, home of my cousin, Little Richard Penniman, and where we hail great with Mercer University, wonderful, the wonderful Air Force Base that's in Warner Robins. So I'm so happy to be able to be representing wonderful things that we have down there. If you haven't been to Macon or Warner Robins, I suggest you get in your car and get there fast because we have a lot to offer.
Thank you. Thank you. My incredible Vice Chair, Representative Stinson.
Thank you, Madam Chair. Patty Marie Stinson, representing House District 150, which includes Taylor County, Macon County, Dooley County, the city of Fort Valley, the city of Andersonville, and the city of Americus. It literally takes me 1 hour to drive from Taylor County to Dooley County. And Taylor County is the home of the Georgia Strawberry Festival, while I serve as the queen.
There you go. There you go.
Mark your calendar. Every April, at the end of April, come on down to Taylor County for some good strawberries.
You are the queen.
Yes, you are. My sweet mate, Representative Byrd.
Good afternoon. I am Charlize Byrd, that represents District 20, and thank the Lord I only have Woodstock, Georgia, in Cherokee County, one county. Thank you.
Thank you. And last but not least, Representative Griffin.
Thank you very much. I represent the old capital of Georgia, which is Millersville. You all didn't know that, did you? That Millersville is the old capital of Georgia? Okay. Yeah, okay. I have most of Baldwin County, which is Millersville, except I think one precinct out across the river. And I have a small portion of Jones County, that's Gray, and East Macon. And in Millersville, we also have Georgia College and State University, which is the liberal arts university in the university system. And we also have Georgia Military College and a lot of other things. So come on down to Millersville.
Thank you. I will serve as your chair lady. I'm Karen Mathiak. I am District 82, which is half of Spalding County and a little bit of Fayette County. I have Brooks, Woolsey, a little piece of Peachtree City, and South Fayette. So with all of that, we are adjourned. Thank you, everybody. I appreciate you being here today.